Today we'll be discussing the pharmacology of CLEVIPREX, clevidipine, including its mechanism of action, pharmacodynamic, and pharmacokinetic properties. But first, let's review the indication and contraindications for CLEVIPREX. CLEVIPREX is a dihydropyridine calcium channel blocker indicated for the reduction of blood pressure when oral therapy is not feasible or not desirable. CLEVIPREX is contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products. Defective lipid metabolism seen in conditions such as pathologic hyperlipemia, lipoid nephrosis, or acute pancreatitis if it is accompanied by hyperlipidemia, and severe aortic stenosis. Complete important safety information for CLEVIPREX will be presented at the end of this video. Let's begin our discussion of CLEVIPREX clinical pharmacology with a brief overview of its mechanism of action. As a dihydropyridine L-type calcium channel blocker, CLEVIPREX, or clevidipine, works by selectively dilating arterial smooth muscle cells via a calcium channel blockade. By decreasing systemic vascular resistance, mean arterial blood pressure is reduced. CLEVIPREX does not reduce cardiac filling pressure, also called preload. This confirms that CLEVIPREX does not have an effect on venous capacitance vessels. In terms of its pharmacodynamic profile, CLEVIPREX has a rapid onset of effect within 2 minutes. In the perioperative patient population, CLEVIPREX produced a 4 to 5% reduction in systolic blood pressure within 2 to 4 minutes after starting a 1 to 2 milligram per hour infusion. During administration, you will need to titrate the dose to achieve your desired therapeutic response. As you increase the dose by 1 to 2 milligrams per hour, you'll typically see a 2 to 4 millimeters of mercury decrease in systolic pressure. This shows how there is a dose-dependent decrease in systemic vascular resistance. The effect of CLEVIPREX appears to reach a plateau at about 25% of baseline systolic pressure. At an infusion rate of around 10 milligrams per hour, you can expect to see half of the maximal effect of CLEVIPREX. An increase in heart rate is a normal response to vasodilation and decrease in blood pressure. You should be aware that these increases in heart rate may be pronounced in certain patients. In studies up to 72 hours of continuous infusion, there were no signs of tolerance or hysteresis. You can expect an offset of effect within 5 to 15 minutes of stopping the infusion of CLEVIPREX. At this point, most patients will experience full recovery of blood pressure. In clinical studies, the patients who received up to 72 hours of continuous infusion and were not transitioned to other antihypertensive therapies showed some evidence of rebound hypertension after CLEVIPREX was discontinued. Now, let's move on to pharmacokinetics. CLEVIPREX is rapidly distributed and metabolized, which results in a very short half-life. The initial phase half-life of CLEVIPREX is about 1 minute and accounts for 85 to 90% of CLEVIPREX elimination. The terminal half-life is also quick, approximately 15 minutes. Steady-state volume of distribution is 0.17 liters per kilogram in arterial blood. And at 37 degrees Celsius, normal body temperature, CLEVIPREX is over 99.5% bound to plasma proteins. CLEVIPREX is rapidly metabolized primarily by esterasis in the blood and extravascular tissues, and is then excreted mostly in urine. Elimination is unlikely to be affected by hepatic or renal dysfunction, so no dosing adjustments need to be made in patients with renal or hepatic impairment. You can find more information about the pharmacology of CLEVIPREX in the full prescribing information and at cleviprex.com. Thank you for watching. Please stay tuned for the full important safety information. Important safety information. CLEVIPREX, clevidipine, injectable emulsion, is contraindicated in patients with allergies to soybeans, soy products, eggs, or egg products. Defective lipid metabolism seen in conditions such as pathologic hyperlipemia, lipoid nephrosis, or acute pancreatitis if it is accompanied by hyperlipidemia, and severe aortic stenosis. CLEVIPREX is intended for intravenous use. Use aseptic technique and discard any unused product within 12 hours of stopper puncture. Hypotension and reflex tachycardia are potential consequences of rapid upward titration of CLEVIPREX. If either occurs, decrease the dose of CLEVIPREX. There is limited experience with short-duration therapy with beta blockers as a treatment for CLEVIPREX-induced tachycardia. Beta blocker use for this purpose is not recommended. CLEVIPREX contains approximately 0.2 grams of lipid per milliliter, 2.0 kilocalories. Lipid intake restrictions may be necessary for patients with significant disorders of lipid metabolism. Dihydropyridine calcium channel blockers can produce negative inotropic effects and exacerbate heart failure. Monitor heart failure patients carefully. CLEVIPREX is not a beta blocker, does not reduce heart rate, and gives no protection against the effects of abrupt beta blocker withdrawal. Beta blockers should be withdrawn only after a gradual reduction in dose. Patients who receive prolonged CLEVIPREX infusions and are not transitioned to other antihypertensive therapies should be monitored for the possibility of rebound hypertension for at least 8 hours after the infusion is stopped. There is no information to guide use of CLEVIPREX in treating hypertension associated with pheochromocytoma. Most common adverse reactions for CLEVIPREX, greater than 2%, are headache, nausea, and vomiting. Please see full prescribing information for CLEVIPREX at cleviprex.com.